Hi everyone, I'm Dr. Sid Sudunagunta, a board-certified veterinary cardiologist working in the UK. I'm pleased to be working with you tonight on Vet Candy's NAVLE prep. Let me tell you a little bit about myself. I graduated from the Royal Veterinary College in 2011. I did complete the NAVLE exam along the way, although I never ended up working in the US. I completed my cardiology residency at the University of Liverpool in 2020 and passed my European board exams the following year. I'm currently working at a multidisciplinary hospital in the middle of the UK. I'm looking forward to discussing some cardiac topics with you. I hope you found them helpful for the exam, but also for your career going forward. If you have any questions for me, just post them in the chat and we'll answer them for you. Okay, let's get started. This session will cover ECGs. Sorry, I know in the USA you call them EKGs. I'm just so used to saying ECG, I don't think I'll be able to switch for the session. I've prepared some images of ECGs, which I hope are helpful. There is a logical way to approach them, but there's also a benefit to experience and pattern recognition. I'll start with a quick overview of normal conduction. An electrical impulse originates in the sinoatrial node, or the pacemaker, spreads across the atria, and also travels to the atrioventricular node, also called the AV node. Atrial depolarization is seen on the ECG as the P wave. In the healthy heart, this is the only way for the ventricles to subsequently depolarize. The AV node slows conduction, allowing the atria to fully depolarize and fill the ventricles. This pause is the PR interval on the ECG. The impulse then travels down the specialized conduction pathway, the bundle of His, the left and right bundle branches, and Purkinje fibers to the ventricles. This allows coordinated ventricular contraction and is the quickest and most efficient way to depolarize the ventricles. Ventricular depolarization is seen with the QRS complex. Under normal circumstances, the QRS complex should be tall and narrow, indicating that the impulse has traveled from the atria via the AV node and specialized conduction pathways. Finally, you have repolarization and the T wave. This is a normal or sinus heartbeat. It's a simple definition, but one people sometimes forget when confronted with an ECG. Remember that ECGs are essentially a graph of electrical activity over time. They can be pretty daunting, but there's a relatively finite manner in which the atria and ventricles can interact or not interact, and we will cover the important changes and arrhythmias now. First off, I'll talk about supraventricular tachycardias. First, there are a group of arrhythmias that are collectively termed supraventricular tachycardias. These are arrhythmias that occur above the ventricles and AV node, so typically originating within the atria. Supraventricular tachycardias are characterized by abnormal P waves, but they usually have normal QRS complexes because the ventricles are depolarized normally. Atrial fibrillation is the most common type of SVT, but it is also unique in its electrophysiological characteristics and merits a special mention. Atrial fibrillation is the most common arrhythmia in dogs. It typically occurs in the presence of structural heart disease with atrial enlargement, though some large breed dogs can develop atrial fibrillation prior to the development of structural changes. This is pretty common in Irish wolfhounds. In humans, this is called lone AF. In dogs, the term is maybe a bit controversial, and it is suspected that atrial fibrillation is an early sign of cardiomyopathy. In atrial fibrillation, rather than atrial depolarization being controlled by the sinoatrial node, there is constant random activity throughout the atria, which causes intermittent and variable AV node conduction and ventricular depolarization. Patients with atrial fibrillation have a pretty typical auscultation. The heart rate is totally irregular, often pretty fast, and there are pulse deficits. The faster the rate, the more variable the pulse quality, and the greater the discrepancy is between heart rate and pulse rate. The ECG in atrial fibrillation has a characteristic appearance with three important findings. First, there is no P wave, because you do not have an impulse from the sinoatrial node and coordinated atrial conduction. In some patients, you may see baseline fibrillations, called F waves, but these do not need to be present. Secondly, the QRS complexes are tall and narrow, because this is still a supraventricular rhythm, i.e., one which travels down the specialized conduction pathway to depolarize the ventricles. There are some specific circumstances under which this doesn't happen, but they are rare. Third, the rhythm is irregular. Again, there is no coordination from the sinoatrial node, so the ventricles contract in a totally random rhythm depending on the signals from the fibrillating atria. Patients with atrial fibrillation can undergo rhythm control therapy, which aims to restore sinus rhythm, or rate control therapy, in which medication is given to slow the ventricular rate, which improves cardiac output. Restoring sinus rhythm is desirable, however, it is very rarely successful in patients who have structural heart disease, which is to say, most patients with atrial fibrillation. A small proportion may respond, though. Rhythm control is often obtained by electrical cardioversion. In terms of rate control, the most commonly used drugs are diltiazem and digoxin. The combination of these two has been shown to be more effective than monotherapy with either agent. Other drugs, such as amiodarone, can be used. The next supraventricular tachycardia to discuss is atrial flutter. Atrial flutter is less common than atrial fibrillation, but it has some conceptual similarities. Flutter also occurs secondary to atrial enlargement, most commonly the right atrium. In flutter, there is a circuit of electrical activity depolarizing the atria rather than the sinoatrial node. This is more organized than in atrial fibrillation. As such, the atrial activity on the ECG is more uniform. However, you still don't have normal sinus P waves. Instead, the typical appearance is this uniform sawtooth flutter wave appearance. Again, just as in atrial fibrillation, the QRS complexes should be tall and narrow. In atrial flutter, the atrioventricular conduction is not perfectly regular. There usually is some pattern to it. So in the example shown, there are periods of 3:1 and 4:1 flutter. It's quite difficult to distinguish between atrial flutter and fibrillation on auscultation alone. The management of atrial flutter is similar to that for fibrillation. Diltiazem can be given to slow the ventricular rate. Sotalol can also be effective. Restoration of sinus rhythm by electrical cardioversion can also be attempted. Finally, there are a few centers around the world who perform electrophysiology testing, and they are sometimes able to identify the source of the flutter and ablate it, restoring sinus rhythm. The remaining supraventricular tachycardias are much less common and are difficult to differentiate on ECG alone. They are characterized by a typically fast, regular, narrow complex ventricular rhythm. Sometimes abnormal P waves, called P prime waves, can be seen. This ECG shows an SVT in the initial part of the strip. You can see a very fast, narrow complex rhythm without clear P waves. Just after halfway, the rhythm breaks, and you have resumption of normal sinus rhythm with a P wave followed by a QRS complex. Next, let's talk about ventricular arrhythmias. Ventricular arrhythmias are typified by the presence of ventricular premature complexes, or VPCs. VPCs occur when the ventricles beat in the absence of depolarization from the atria and via the AV node and His-Purkinje system. An ectopic focus within the ventricles can spark a wave of depolarization, which causes ventricular contraction. Because this impulse does not travel via the specialized conduction system, the depolarization travels slowly, causing a wide QRS complex. Remember, the ECG is a graph of electrical activity over time, so a wide complex indicates a longer duration of activity, slower conduction. This first ECG shows alternating normal sinus beats and VPCs. You can see the sinus beats have a P wave followed by a narrow QRS complex. This next ECG shows 4 normal beats, then 2 VPCs next to each other, termed a couplet. You can usually hear VPCs on auscultation. A beat will come in earlier than expected, and there is often an associated pulse deficit, or at least weaker pulse quality. VPCs can occur singly or in isolated fashion. You can have 2 or 3 in a row, a couplet or a triplet. These VPCs don't typically need treatment. The approach is centered around determining the underlying cause. Runs of VPCs over a rate of approximately 160 to 180 beats per minute are termed ventricular tachycardia. This can occur in brief paroxysms or as longer, sustained periods. On the ECG, there is a rapid, wide QRS complex rhythm. The longer ventricular tachycardia persists, and the faster the rate is, the more dangerous it is. Ventricular tachycardia can cause weakness, collapse, or even sudden death. On auscultation, ventricular tachycardia is almost always regular, with variable pulse quality and pulse deficits. Similarly to atrial fibrillation, the faster the tachycardia, the more dramatic the pulse deficits are, because the heart doesn't have time to fill and pump a reasonable volume of blood between heartbeats. This image shows one sinus beat at the start. Then the rhythm abruptly switches to ventricular tachycardia. You can see the QRS complexes are wide and the rate is really fast. When trying to identify ventricular beats, it definitely helps to have normal sinus beats to compare them to. Often with fast ventricular tachycardia, you won't be able to see P waves as they get lost in the larger electrical signals caused by ventricular depolarization. Remember, the cardiac conduction is not uniform, so there may be P waves, but they are not associated with the ventricular beats. Ventricular tachycardia is often an emergency, and it is critical to restore sinus rhythm as quickly as possible. The first-line drug of choice for this is lidocaine, which is given as a bolus and/or a CRI, a constant rate infusion, while oral therapy is initiated with something like mexiletine, sotalol, or amiodarone. In some cases, often dogs with systemic, particularly gastrointestinal disease, you will see a slower ventricular rhythm. This is called accelerated idioventricular rhythm. It is a ventricular rhythm that isn't fast enough to be called ventricular tachycardia. Accelerated idioventricular rhythm often occurs at around 120 to 160 beats per minute. Because accelerated idioventricular rhythm is not excessively fast, it typically isn't necessary to treat with antiarrhythmics. Next, we'll talk about bradyarrhythmias. I think the most important to cover, both from an exam point of view, but also in the context of what you will see most commonly, are atrioventricular blocks and sick sinus syndrome. Atrioventricular block is the term for alteration of conduction through the AV node. Remember, under normal circumstances, the AV node is the only route for impulses to travel from the atria to the ventricles. It's a hugely important structure. The node delays conduction, which allows the atria to fully depolarize and empty before ventricular depolarization. This allows for optimal ventricular filling, which will obviously result in the best cardiac output. This delay function is really important in the context of arrhythmias, such as atrial fibrillation. If the atrial depolarizations are excessively fast, it could result in rapid ventricular activity if the signals aren't delayed. But if AV nodal conduction is impaired, it can result in severe bradycardia with too few signals reaching the ventricles. AV nodal conduction can be affected by physiological factors, so increased vagal tone can cause reduced conduction. It can also be modified by drugs, particularly sedatives and anesthetics. Alpha-2 agonists, such as medetomidine, tend to cause really dramatic changes. Alpha-2 agonists, such as medetomidine, tend to cause really dramatic changes. And finally, disease states can cause changes to nodal function, either systemic illness or primary damage to the node. In theory, things like endocarditis, myocarditis, or neoplasia of the node can occur. Age-related degeneration is also feasible, and I believe it's thought to be the most common cause of pathological AV block. We'll start with first-degree atrioventricular block. First-degree AV block is a delay in AV nodal conduction. This can reflect increased vagal tone, can be drug-induced, etc. Certain dog breeds, particularly brachycephalic dogs, often have high vagal tone and may have first-degree AV block as a normal finding, particularly during sleep. On the ECG, there is a prolongation of the PR interval, which indicates the delay in conduction. But all P waves are followed by a QRS complex, i.e. all the impulses get through. First-degree AV block is not clinically significant. There is no impairment to cardiac output, but it may alert you to other problems like inappropriately high vagal tone. Next, we have second-degree atrioventricular block. Second-degree AV block is intermittent failure of AV nodal conduction. On the ECG, there will be occasional P waves that aren't followed by a QRS complex. There are two types of second-degree AV block. Mobitz type 1 second-degree AV block is thought to be vaguely mediated, similar to first-degree AV block. It's not clinically significant, there is no impairment to cardiac output, it's considered to be physiological rather than pathological. The characteristic ECG finding is prolongation of the PR interval before a block. This is called the Wenckebach phenomenon. Mobit's type 2 second-degree AV block is more likely pathological. In this form, the PR intervals are constant rather than prolonging. The milder second-degree AV blocks may not need treatment. However, if there are a lot of blocked P waves, particularly consecutively, termed high-grade AV block, then treatment may be indicated. Some dogs respond to medical treatment to increase heart rate and reduce vagal tone, for example, atropine, terbutaline, theophylline, hyoscyamine, etc. Symptomatic dogs with more severe second-degree AV block may need pacemaker implantation. Next, we have third-degree atrioventricular block. In third-degree AV block, there is a complete lack of communication between the atria and the ventricles, resulting in lots of unconducted P waves, as the sinoatrial node and atrial depolarization work normally, but the impulses don't travel through the AV node. The cause is often not established. Lots of conditions have been reported, including myocarditis, endocarditis, neoplasia, age-related node degeneration, Lyme disease, etc. The ventricles have their own internal pacemaker, which is there as a fail-safe, the idea being that if something like this happens, the heart doesn't stop altogether. So the ventricles can beat at a rate of 30 to 60 beats per minute to keep the dog alive. This is called an escape rhythm. This is only useful in the short term, however. With prolonged bradycardia, you can have collapse, cardiac dysfunction, and even sudden death. The ECG in third-degree AV block shows lots of unconducted P waves and a slow ventricular escape rate with wide QRS complexes that are not associated with the P waves. Third-degree AV block is often an emergency with pacemaker implantation required. Medical management is very rarely effective. The last condition I'm going to talk about is sinus node dysfunction, or sick sinus syndrome. Sinus node dysfunction is the name for a degenerative conduction system disorder that causes various arrhythmias, mostly bradyarrhythmias, though you can sometimes get supraventricular tachycardias as well, so-called brady-tachy syndrome. A decent proportion of these dogs will remain asymptomatic with no treatment required. However, sick sinus syndrome is the term for dogs with sinus node dysfunction who develop clinical signs, most commonly lethargy, collapse, and syncope. Sudden death is reported, though it is rare. Sinus node dysfunction can affect dogs of any breed. However, it is most common in older, small breed dogs, particularly West Highland White Terriers and miniature Schnauzers. The ECG findings can be very varied, from sinus bradycardia, pauses, varying degrees of atrioventricular block, and some tachycardias. This is an ECG from an old West Highland White Terrier with sick sinus syndrome. It shows sinus bradycardia with a heart rate of about 70 beats per minute. There are also occasional pauses of a couple of seconds. Dogs with suspected sick sinus syndrome should have an atropine response test performed. This abolishes vagal tone and may increase the heart rate in some patients. Patients who respond well to atropine may also do well with oral anticholinergic medications or other drugs which increase heart rate, e.g. terbutaline, theophylline, hyoscyamine, etc. Patients who don't respond to atropine often require pacemaker implantation to control the clinical signs. Okay, let's do a couple of questions. Feel free to put your answers in the chat. First up, a 7-year-old boxer presents after a few days of lethargy, poor appetite, and reduced exercise tolerance. The heart rate is approximately 250 beats per minute with a regular rhythm, and you notice significant pulse deficits. You perform an ECG and see this. What is the rhythm diagnosis and treatment of choice? Is it A, atrial fibrillation, treated with oral diltiazem and digoxin? Is it B, atrial flutter, treated with electrical cardioversion? Is it C, ventricular tachycardia, treated with intravenous lidocaine? Is it D, second-degree atrioventricular block, treated with oral terbutaline? Or is it E, accelerated idioventricular rhythm with no treatment required? What are your thoughts on the correct answer and why? Let me know in the chat. Did you get it? The correct answer was C, ventricular tachycardia, treated with intravenous lidocaine. There is a very fast, wide QRS complex tachycardia consistent with ventricular tachycardia. Given the high rate, urgent treatment to restore sinus rhythm is indicated. Option A, atrial fibrillation, was incorrect. The wide QRS complexes and regular rhythm are not consistent with atrial fibrillation. Option B, atrial flutter, was incorrect. Again, wide QRS complexes are not consistent with atrial flutter. Furthermore, flutter waves cannot be seen on this ECG. Option D, second-degree atrioventricular block, was incorrect. This is a tachyarrhythmia, and P waves can't be identified, therefore can't be deemed to have been blocked. And finally, option E, accelerated idioventricular rhythm, was also incorrect. The wide QRS complexes and regular rhythm are features of accelerated idioventricular rhythm. However, the rate is too fast. Rates above 160 to 180 beats per minute are termed ventricular tachycardia. Okay, let's do one more question. A 9-year-old crossbreed dog presents after having had a collapse episode. You identify a heart rate of 45 beats per minute with a regular rhythm and no murmur. You suspect third-degree atrioventricular block based on the ECG. What is the treatment of choice? Is it A, theophylline, B, furosemide and pimabendin, C, chemotherapy, D, pacemaker implantation, or E, only monitoring with no treatment at this stage? What are your thoughts on the correct answer and why? Let me know in the chat. How did you do? The correct answer was D, pacemaker implantation. Pacemaker implantation is necessary to restore a normal heart rate and stop the patient from collapsing. Up to 10% of dogs may spontaneously recover from their third-degree AV block. However, even if it were to happen, it's not possible to give a time frame, and immediate action is needed. Option A, theophylline, was incorrect. Dogs with third-degree atrioventricular block don't typically respond to anticholinergic drugs or other rate-increasing therapies. Option B, furosemide and pimabendin, was incorrect. It's not clear that this patient is in congestive heart failure. Option C, chemotherapy, was incorrect. While neoplasia is a possible cause of AV block, chemotherapy will not address the main concern, the severe bradycardia. And option E, only monitoring with no treatment at this stage, was incorrect. This patient is symptomatic and ideally intervention should be pursued. Okay, that's it for tonight on this episode of Vet Candy's NAVLE Prep. Hopefully you enjoyed our talk and found it helpful for your studies. If you have any questions, please be sure to put them in the chat. Good luck on your exam. All the best.